Okay, good afternoon, everyone. It is 2 o'clock, so I'll start our meeting. Welcome to this meeting of the Leicestershire Health and Wellbeing Board. The meeting is being held remotely and is being broadcast live via the County Council's website, and it will be archived so it can be viewed afterwards. Before we move on to the first agenda item, I'll quickly confirm the names of those members of the board who are joining us today. From the County Council, I have Mrs. Taylor and Mrs. Radford. I have John Wilson and also Mike Sands, who will be arriving late because he's in another meeting, and also Jane Moore. From the clinical commissioning groups, I have Andy Williams, who again will be arriving late, as will Rachna Vyas. I should have Caroline Trevithick and also Dr. Ahau. From the districts, I have Councillor Kaufman, Councillor King, and also Jane Toman. I also have from the clinical commissioning groups, Professor Lakhani. Apologies, Mayor, missed your name off the list. LPT's Helen Thompson. From UHL, we should have Mark Whiteman. From the police, we should have Chief Superintendent Adam Streets. From the Police and Crime Commissioner, welcome to Lord Back. And from Healthwatch, we should have Harsha Katecha. So good afternoon, all. If I've missed anyone, I apologise. May I remind members, turn your microphones on when you want to speak and off again when you finish speaking. If people are having broadband issues with screens freezing, I just suggest that you freeze your video and it should give you better access when speaking. If you want to speak, can we use the raise hands, because we don't tend to use the chat because it's often hard to monitor. So if you avoid the chat messenger function, and please use the raise hands if you wish to ask a question or speak. Apologies for absence. I have received apologies today from Richard Blunt. We've got Mrs. Radford substituting, from John Sinnott, from Dr. Vara Kantam, and we've got Dr. Ahau subbing for him, and also from Hayley Jackson. And I've had late apologies from Mukesh Bharat from Healthwatch, who has a family matter to deal with. So without further ado, I shall move on to item 1 on the minutes. I propose that the minutes of the meeting held on the 26th of November 2020 be taken as read, confirmed and signed. Okay, thank you. Item 2, urgent matters. I have no matters that have been declared to me urgent. Item 3, declarations of interests. Do any board members have any interests they wish to declare in respect to any items on the agenda? I have 9 people on my screen. I'm sure we got more attendees. So yeah, if you do have a declaration, just again use the raise hand. So thank you. Item 4. Yes, Jeffrey.
Yeah, my son works for NHS England, based in Derby or Leicester. Perhaps I ought to declare that.
Okay, all right. I'm sure Matt's got a copy of that, so thank you for that. Item 4 on the agenda is my position statement. Copies have been emailed to you today, and a version is also published on the Council's website. My position statement includes an update concerning the local response to the coronavirus pandemic, including all the information on the numbers of patients being treated in hospital, as up to date as it can be, the vaccination programme, and also the delivery of adult social care. Do any members have any questions that they wish to ask regarding the update? I would just say, I think on behalf of the board, I think I just wish to thank all of those people who are working and managing in the delivery of the local response and the recovery work that we're doing. So hats off to you for the work you're doing in these unprecedented times. So yes, on behalf of the board, thank you. Position statement also includes some information concerning the joint strategic need assessment process and the current cycle, which has come to an end in March of this year. 17 chapters have been published so far, with the findings of some which have been presented to the board. The next cycle of the JSNA will commence in March 2022, and the board will be updated with a draft programme of those chapters in due course. Amongst several other things, the position statement also detailed the County Council's campaign and continued promotion of its Down to Us campaign, the start of conversation and the mental health campaigns that we've been also promoting and working with other partners, the weight management service, and also the Leicestershire Warm Homes Fund project. So, Councillor King, you have your hand raised.
Yeah, good afternoon, Lee. Good afternoon, everyone. Thank you for that. No, I have read your position statement, and I would endorse the comment that you just made about everyone who's working in the in the front line, so to speak, and in back offices as well, to make the vaccination program a success, and also the testing, and also the hospitals in the acute care side as well. But just moving on to your joint strategic needs assessment comment, I do think that is very important, that those two outstanding items do get completed in the next year, because they are vitally important to understand, particularly the one around carers, unpaid carers, because they do provide much of the backbone of informal care across the county, for people who have long-term disabilities and health needs, and which is obviously going to be a factor over the coming year or two, with the longer-term impacts, which we're still finding out about from people who've recovered from sadly from COVID-19. So it's going to be an increasingly important thing for us to understand, not just members, but also for the various agencies and groups that make up this board, to understand how we can make a difference, and all of that. So just what I wanted to say. Thank you.
Okay, yeah.
Cheers.
I think certainly the officers and everyone involved, dementias and carers are important. I think that will be prioritised within the next year's work. So yeah, thank you for that, Phil. Okay, I'll move on. If you'd like to drop your hand, Phil, I'll move on to item 5 on the agenda, which concerns technology-enabled care. This report provides members with results of diagnostic work undertaken to explore opportunities to maximise the use of technology-enabled care across the adult social care pathway and set out the proposed way forward. Today we're joined by Nigel Thomas, who's the Assistant Director within the Council's Adult and Communities Department, and he will present the report. So good afternoon, Nigel, and I'll hand over to yourself. Thank you.
Thank you, Chair, and good afternoon, everybody. The purpose of this report really is, just as has been said, just to outline the results of a piece of diagnostic work that we undertook with Hampshire County Council last year to explore how or whether there were any opportunities to optimise our use of what we call technology-enabled care, or TEC, to enhance people's outcomes in terms of social care needs in the community. When I'm talking about TEC here, I am talking about customer-facing technology. So technology that you or I might use in the home that can maybe assist us with a variety of tasks in the home, reminding us to do things or monitoring aspects of our health and well-being. And within the department, the Adults and Communities Department, I think we've been aware for some time that we really needed to do more to explore the opportunities that technology-enabled care presented us with. We wanted to sort of understand whether it could deliver results, whether there was a financial business case to make that case for transformation, and whether it would actually provide a platform with us to transform our care offer as part of the service that we offer residents. So to that end, we commissioned Hampshire County Council, who have a strong track record and are probably one of the most advanced authorities in their use of technology, to do some work with us to look at what our current offer is, and then to say where the opportunities might lie in terms of how we develop a tech offer. And as I've said, tech can do a number of things. It can be off-the-shelf, standalone pieces of technology. Many of us might have a smart speaker, an Amazon Echo Dot that we can program to remind us to do things throughout the day. But they can lead to more sophisticated monitoring technology that can track, if we're elderly, that can track our movements in a house and alert friends and family if perhaps something goes wrong. So we entered we undertook a piece of commissioning work with Hampshire County Council, and they did a number of things. They looked at what our current offer was. They carried out a range of interviews with departmental staff and other stakeholders, and the executive summary, which is attached to your report, made a number of findings. One is that our current approach to care technology is fragmented. We do have an assistive technology team, and we're conscious that district councils have an alert pendant offer, but that is varied across that landscape. And it isn't a holistic and an end-to-end offer. It can be fragmented, and it can lead to confusion when we're offering advice and support to people. There's a strong appetite amongst practitioners within the department and through other stakeholders for change. But there are some barriers in terms of knowledge and training and understanding what the technology landscape can actually offer. And the report suggested that we needed to make some commitment and investment into undertaking, sort of making sure we've got a clear vision for what we wanted to do, make sure that we've got some clear commissioning intentions, but also importantly to establish care technology as a first offer for adult social care. But importantly, not replacing any care. The use of technology must be very much based on service outcomes. And if it wasn't appropriate, then it shouldn't be used. So it's not, and I think it's important to understand that in this case, it's not a tech for tech's sake. It's the use of tech where there is a demonstrable benefit to helping people meet their outcomes and help them to live independently at home. So in the report on paragraphs 18 and 19, you've got some examples there of what that change might look like in practice. So there's a couple of case studies that look at how tech can be used to either make people more confident, but also go about their work and their work. And case study 2 there is somebody that worked, in fact, for the NHS, had a long-term epilepsy, and they were really worried about accessing and commuting to work because of their increased seizures. So in this case, a small personal alarm with a GPS tracker was supplied to enable them to activate in case of an emergency. And that gave them the confidence and sense of safety to continue to go to work, but also it provided some reduced domiciliary care. So the use of the tech was enabling us to reduce actually domiciliary care in that particular instance. We wanted to understand, most importantly, if there was a financial benefit for making greater use of technology. And within the report, Hampshire looked at a number of scenarios, and these are detailed on paragraph 21 of the report. So there are 4 scenarios there. The first scenario looks at us supporting some 3,500 users at the end of a 5-year period. And that would generate a cumulative net benefit of somewhere perhaps around 5.4 million, allowing for some 2 million of incremental care technology costs. They also looked at a scenario which said, well, we may support less users. So this is about supporting 2,700 users, but still generating the same amount of benefit. The third scenario is looking at reduced benefits. So in that scenario, we're still supporting 3,500 users, but there's less actual benefits. And then the fourth scenario was we have reduced growth and reduced benefit. So we support less than 3,500 users, there's less benefits. But in all of those cases, there was a net benefit to be had, whether that be through avoided costs in other areas of what a care package might look like, or cashable savings. So they presented 3 options for if we wanted to take this forward, how could we do it? The first option was we can commission a county-wide transformation approach and establish an end-to-end service driving for tech change. The second option is we could adapt and grow the existing assistive technology service. And the third option was to develop a hybrid model, which was a mixture of the two. And based on that report, our current approach and drive is really to progress with that first option, a county-wide transformational approach, which would involve a lot of cultural change, but would establish an end-to-end service, which is probably more holistic and more strategic as well than the one that we currently offer. So essentially, that's the essence of the report. This has been to our internal scrutiny, and a report that is scheduled to go to Cabinet next week, with that recommendation that we progress with that transformational approach to care. You'll see in your pack that there's the executive summary of that report, which covers the main points that I've just dealt with. So happy to take any questions on that.
Okay, thank you, Nigel. It is interesting the work that Hampshire have done. I think it does make sense, and I think it's something that we've known for a long time. That technology does, it does help, and certainly savings are made to be there. It's just delivering it into the in the quantities and to the users. So, can I just ask, Christine, is there anything you'd like to add? Obviously, you're subbing for Richard as support member for adults. So, Christine Radford, anything you'd like to add?
No, not at the moment. I think that was well summed up, Nigel. I just think it's a way to move forward. It's not just to saving money, it's to get the best for our users and residents that need support. I think, and to give their what am I going to say? The people who look after them as well, a benefit as well. Thank you.
Okay, thanks, Christian. Okay, I've got 4 questions. I'll do them in order. First of all, Councillor King.
Yeah, thank you. Thank you, Nigel, for your presentation. I've got a couple of questions and just some observations. So first of all, the question I have is, didn't the County Council used to operate a county telephone care system through a company called, was it Tunstall? Didn't you used to have that system, and you got rid of it a few years ago? So I'm just kind of a bit whether that was the case. But irrespective of that, I think this is potentially quite an exciting project, but I'm a bit concerned by what you've said about going for a county-wide transformation project, because I actually think there's a lot of really good work that, for example, the light bulb project does with the, ensuring residents get adaptations and all those sorts of things in their properties, where there's a lot of joined up working already. Also, districts, one of which is Harborough, which I represent. We have a very well-established what's called Lifeline service. You put down as slightly dismissive what is in the report actually about what these services actually already do. I think. They do a lot more than just, respond dependent alarms. And I actually think the potential for utilising what's already there under the management of the districts. For example, in Harbour's case, we actually already monitor over 2,500 resident properties across the county. In fact, it's probably more than that. So it's actually, I think there's a really opportunity to build on what's already there rather than creating from scratch which is, unless I've got that wrong, what you've just said, through a complete transformation program. So I'm kind of I think you're right. There is a lot of really positive technology out there that can really make a difference to people, as Christine said, people's lives, because that's what this is about, improving the quality of people's lives, and at the same time, improving the cost effectiveness of what's delivered. Because obviously, if you're getting lots of calls to somebody's address and you can resolve that by putting in a clock, as the example you put in your report, then that's obviously a relatively cheap solution, and you compare to having lots of expensive calls from carers. And I think we all understand that. So I think that's why it's really exciting. But I just have some concerns that we're in danger of throwing out a lot of really good work that's going on, because at the end of the day, if we need to understand exactly what is being talked about, because if we end up the districts we're investing, we've got digitalization of the phone system that's coming about, we've got to invest in our networks and all of that. And so there are a lot of opportunities to bolt on lots of things, which I think could be advantageous. But that's what I wanted to say. Thank you.
Yeah, if I could respond to that, thanks for that. I'll take the second element of it first. Apologies for that. I think I'll probably be a little bit misleading there. When I talk about a county-wide, I was thinking within the head of our own social care department, of a transformation around the way that we instill technology in terms of our end-to-end processes with those people that are eligible for social care within our department. So apologies, I've just sort of that I can understand why that's perhaps been misleading. I should say that we have had some discussions with district colleagues around the development of this, and I think probably, I don't know whether there's any other district colleagues here, I think the response was generally supportive. So I think, definitely, and Lightbulb definitely would become, sort of part of the way that we put together the specification for what our offer would be. I think within what we're looking to do is to work with a technology partner within our department, focusing on sort of our response with regard to adult social care and people that have got eligible care needs. But also there will be in that spec enough to sort of open the door for other partners and stakeholders to become involved. And I think very much the point that was made from that engagement with district colleagues was that Lightbulb was going to be a critical part of all of this. So yes, apologies if I sort of misled there. I was thinking of it in my mind in terms of how we transform the social care pathway, so that people have got an opportunity to, depending on what their outcomes are, be an opportunity to source appropriate pieces of technology that may help them keep independent in their homes for longer. Just picking up the second point about the telephone line, I think that must have been quite a while ago, so I haven't got, I don't go that far back in terms of my involvement in adult social care to remember what that was. I don't know whether John can remember if he's on the call, but it certainly doesn't take place at the moment. I think what we're talking about here is sourcing and application of appropriate technology, not necessarily a response service. I'm not sure, in terms of our specification, that's the route we want to take. This is about making sure that we're making the widest use of technology. And it's not just about pendant alarms, as we said, sort of it is a much more holistic look at what all sorts of technology can help us with help people.
Okay, thanks. I was going to say, John is on the call. John, you got your hand raised. Did you want to raise a point on that?
Yeah, hi, good afternoon. Yes, I'm happy to. So yes, we did have a contract with Tunstall. That's absolutely right, Councillor King. That contract lapsed a couple of years ago, but we still use some of the Tunstall equipment. We use it predominantly for assessment purposes, so particularly around our reablement services, where we will, on a short-term basis, provide people with equipment, monitoring equipment and other forms of equipment. We then direct people to, having had the assessment, to what might be an appropriate provision if they require one. And either we will support them to install that, or we'll ask them to do that themselves, depending on the circumstances. I think what's different about this approach is that we're not aligning ourselves to a single organisation, a single provider of technology. What we're looking to do is partner with a broker that can access technology from any company, as opposed to just having a contract with Tunstall. Tunstall might be one of the companies, obviously. The other thing just to say is, in terms of the response service, and obviously one of the recommendations in the report today is to consider the partnership implications and the partnership opportunities. And one of those opportunities is to ensure that we align with the existing response services within the county, because we're not looking to purchase or to procure or to commission a response service as part of this. So if there are existing response services, then obviously we'd want to work with districts to utilise those provisions.
Okay, thanks, John. Next, I've got Jeffrey, Councillor Kaufman.
Thank you, Chair. I wanted to make the point, please don't invent the wheel again. I really do think that light bulb is the best means of delivering it, because it is directly via the districts and the districts working together. I'm a bit concerned, as I think Phil was, that we're reinventing the wheel and we're going to double up on something. Light bulb is doing a good job. That's the way this should be administered. I mean, it's very exciting, the stuff you've come up with. I mean, it really is exciting. It's good stuff for the future, particularly, as you say, it's to supplement the human bit and not to replace the human bit. But please don't set up another organisation to replicate what is already there with Lightbulb. Thank you, Chair.
Okay, thanks. I mean, certainly the County Council fund a lot of money's into the Lightbulb project, and I think, as John's just said, they are looking to develop that partnership approach, but looking at this aspect of what the council delivers. So, okay, thank you. Next, I have Jane.
Thank you, Chair. Really just links to that. So I think Nigel has presented sort of the adult social care perspective, and quite rightly the district members have highlighted the opportunities for Lightbulb. I think that sits really in terms of prevention, and, you know, I'm really pleased for conversations about not only how we feed into the specification and how the Lightbulb programme can incorporate the need identification into their housing MOT, but we've also talked about perhaps running a pilot to try and understand what that Lightbulb offer could look like. I think there's the other point as well is the DFG allocation, which members will be aware sits within the Better Care Fund, and this year certainly not only have we had considerable underspend due to the fact that we've been unable to get into properties, but actually also we've had another injection of funding. So with the DFG review still outstanding, and with that encouragement that it needs to be more transformational, I think there is a really good opportunity to you know, incorporate Lightbulb into this offer, and just some reassurance that those conversations are ongoing, whilst recognising that some districts have their own offers. So thanks.
Okay, thanks, Jane. That's useful. Next, I've got Mayor.
Yes, a very good report, and I fully support the direction of travel and the choice of option one. My suggestion was that maybe we could do a project with the NHS around use of what's called digital assistance, particularly in the context of the post-pandemic world. You know, we're going to see a lot of social isolation, loneliness, mental health problems. There are some pilot studies of devices like Alexa being placed in people's homes, So, reminder for medications to be taken, or call someone when there's a crisis, or even, tell me a joke, or something like that, a bad joke. But it actually improves people's sense of well-being. There's very small amount of evidence. It's not great, but I think this could be a relatively inexpensive way of tackling loneliness and social isolation. So maybe we could do a pilot or trial, especially in the post-COVID world, I think.
Okay, thank you for that. Next, Andrew.
Yes, thank you, Chair. I welcome the approach of bringing technology into these sort of scenarios we're in this situation. Although I think it's worthwhile perhaps us just remembering that not everyone is able or willing to embrace new technology, and it's just really a question about how we ensure that by promoting and providing new technology, we don't inadvertently widen a digital inequity gap. And making sure that as part of the strategy and the plans that we have, is there any way we can support those who wouldn't ordinarily be able or willing to engage with new technology as part of their everyday lives, and how we make sure that we can perhaps support them with training or additional resource to be able to embrace some of this, because they potentially can benefit from it. Thank you.
Okay, thank you. And finally on this, I've got Mark.
Yeah, thanks for the presentation, Nigel. And it was not too late. Happy New Year, colleagues. We haven't seen each other since before Christmas. Clearly, this is kind of part of the future, isn't it? It's not a kind of a digital bullet that's going to solve all ills. And I know that's not what you're saying. I'm just conscious that the NHS is focusing very heavily on digital wearable technology for things like medicines management and the treatment of chronic respiratory disease. And I'm also really conscious that your client base is not that dissimilar from ours in lots of circumstances. So just extending that metaphor a little bit. We know that there'll be certain cohorts of the people that you serve and the people that we serve that might get multiple visits from multiple different agencies every day or every week. And what we can't do is just translate that into multiple pieces of technology that replace people. I know that's not what you're saying. So I'm just thinking, and I know it's in your paper somewhere, Nigel, but somewhere between adult social care and the NHS looking after frail and multimorbid, lonely people, as Mayor says, if we could think about how we're better together on some of that stuff, so we're not getting 3 or 4 devices in everybody's home, but maybe 1 or 2 devices that people actually use more frequently, and actually we might share the burden on cost. And if it would be helpful, I'd be very happy to plug you into somebody at NHSN that would perhaps help your thinking, or indeed you could help our thinking on that kind of stuff.
Yeah, thanks for that. Those are really helpful comments. Yeah, certainly would, anybody that you can plug me into in terms of further out that discussion would be most useful. It is going to be a challenge because there is that sort of borderline between social care and health, where some of the tech that we might be using then blurs into some of the more, sort of technical parts of the tech that's maybe going to help people in terms of more acute health issues. So, it will be a challenge. And I think, the key to that is making sure that we have got those contacts and we are plugging into the right groups and what have you to think about how that works. I think one of the benefits of having a partner that we're suggesting is that one of the things that we want them to help us do is think really strategically about where we can broach those blurring areas, and also keep an eye to the future landscape, how things like artificial intelligence and so forth can be adapted and used. And we know that in Hampshire, for example, they're beginning to experiment with sort of robotics in terms of helping people in the home. So there's a whole fast emerging landscape out there that I think really is important, more than anything else, that sort of health and social care work together on those things.
Okay, thanks, Nigel. Yeah, thank you. I've got Phil. You've got your hand back up again, just for a final comment or question.
Yeah, well, thanks, Chair. It was really a final comment. I just wanted to pick up what what Jane Toman said, to support what she said. Really, I think there are a lot of, as has just been explained by Andrew and Mark, there are quite a lot of health inputs in this. It's cross-cutting, isn't it? It's cross-cutting across health, social care, housing, all those things. And that's when, as districts, we kind of interested in that. And I think it does need potentially, it does really need a pilot, I think, to try to work out how best this is going to work, if at all possible, because otherwise we're in danger of, setting things up and then finding they don't work terribly well, or there's not enough integration with health, or it's not enough integration with districts. And I think, we've got a example of where it's working really well, which is the light bulb project program where we've got people who get admitted to hospital then have to have a housing needs assessment to get discharged back, so then we get the adaptations made on that property. And that's essentially what we're talking about, adaptations, but also adding on monitoring of health conditions. So if, for example, someone forgets to take their medication and an alarm alert then goes off somewhere to say, oh, that person's forgotten to take their medication, or they've fallen out of bed. So then there's a fall monitor that knows that person's fallen. They might be unconscious. They might not have had time to push their pendant alarm to say, I need help. But then that alert gets detected, a response happens. Otherwise, they're then on a freezing cold floor for 10 hours before the carer comes in the morning. So, there are consequential, and I'm sure we all can see the advantages. So I think it's really exciting, but I think we just need to, and I would urge, if there was a pilot or two that would happen in different areas, to just test it out and make sure that what you put. But it's so fast moving, some of these things that are going on. That's the other thing. So whoever the partner is, that's really important as well, that they have got access to the myriad of gadgets and software and everything else that's going on. But just picking up what someone said, I've got an older relative that lives in Leicestershire, and during the lockdown, she's been lonely, and we suggested having a mobile phone and video phone, but she wasn't able to work it out how to do it, didn't want to know, wouldn't engage in that. So the consequence of that is, even though otherwise she's fit and well, but she's 89 years old and she won't do it. So therefore, how do you do it? So there are, do you see what I mean? There are exceptions to this engagement with technology. It doesn't work for everyone, and I think that's what we need to be very mindful of as well. But anyway, otherwise, thank you, Chair. Thank you.
Okay, thanks, Phil. Hopefully, Nigel, John, you others as well. I think that's given you good sort of feedback from the board. So, the board, I think it's been well discussed. So, and the board is asked to note the findings of the diagnostic work undertaken to explore the possibilities and maximise the use of tech. Note the conclusions of the detailed business case and the recommendations which will be presented to Cabinet next week at County Council. Consider the opportunities to develop the partnership, which John touched on. I think that's important. And I think the whole conversation we've said, there's so much expertise around the room. We're all doing this work, and let's try and work together to develop that partnership. And note that a further update will be considered by the board later. So look forward to that coming back. And obviously, I think you've heard a couple of people mentioning pilots there, and I'm sure that'll be part of the rollout plan anyway. So I can see on chat there's plenty of good contacts being passed around. So hopefully members are looking at that as well to go forward. So Nigel, can I thank you for presenting the report? Thank you.
Thank you very much. Thank you, everybody. Bye-bye.
Yeah, pleasure. Thanks, Nigel. We'll move to item 6, which concerns the recommendations and actions arising from the Healthwatch report concerning child and adolescent mental health services in Leicester and Leicestershire, pages 33 to 70 of your agenda pack. This report provides the Health and Wellbeing Board with an update on the progress made by the LPT following the Healthwatch report using child and adolescent mental health services CAMS in Leicester and Leicestershire, which was considered by the board at its meeting in September. Paul Williams from the LPT has joined us to present the report. So, Paul, can I hand over to yourself, and welcome to the meeting.
Thank you very much, Chair. Thank you. I'll take the report as read, but I shall just give you a brief background and then perhaps focus in on one of the recommendations and updates on that in particular. I'm expecting this will be of interest, this report, to lots of people, children's mental health being a particular focus point at the minute nationally. This report is really a progress report, as the Chair says, in response to a survey undertaken by Healthwatch Leicestershire in 2019-20, looking at the experiences of young people using our specialist CAMS services. They produced the report in 2020, and I think it was received by this board in September last year. Subsequent to that, we've been developing some actions around there are 9 recommendations that were included in the Healthwatch report, and I've included in the report progress against those. I think probably and rightly I would like to focus on the first recommendation, because I think that will be of the most keen interest to members of this group, although I'm happy to take questions on any of the other recommendations. So the first recommendation was around reducing waiting times between referral and first appointment, and then treatment or care starting. I think I just want to outline a few things, if that's okay, Chair, and then I'll go into questions after that. I think it's important to recognise that actually, although the first assessment within a specialist CAM service doesn't constitute the start of treatment for the purpose of our pathway, that part of undertaking an assessment does include some psychoeducation and signposting for self-help whilst waiting for treatment. So I think I just wanted to make that point. We have managed to maintain our position for first assessment with regard to our key performance indicators. So for our routine and both our routine and urgent assessments, we've had some real challenges this year, as all services will have had in light of COVID. And I think probably the summary there that's included in the update is that we haven't made significant progress in reducing our length of waits for treatment post-assessment in light of COVID. Initially, when at the onset of the pandemic, I think we were spending, we had to redirect a lot of resource into setting up some urgent care systems for people in crisis mental health. So we set up a 24-hour urgent care hub and a central access point, which was in essence a 24-hour self-referral project for people, for young people experiencing acute mental health needs. And we had to set that up from our existing workforce. So that was in response to a national demand, and we did that really successfully. Since schools opened in September, we've seen a significant increase in our referrals into CAMS. Appropriate referrals currently are up about 25% from pre-COVID levels. And within that, we're seeing a marked increase in complex referrals and children and young people with significant high risk needs. That is adding to our difficulties in taking other children off our waiting list, because we have to prioritise our highest risk children and young people. We're also seeing quite significant increases in our children's eating disorders and our CAMS crisis service referrals as well. So we're presented with quite a lot of challenges, notwithstanding all the other challenges that everybody else has around the reduction in face-to-face appointments, the need to stagger appointments, staff members not being available, trying to get to grips with alternative technology such as video conferencing, etc. So I just wanted to sort of outline that really. We have, as I said, we have found that quite difficult and quite challenging. Certainly over the summer, we've started to reduce our waiting lists again for treatment, but since schools reopened in September, we found that difficult to do. The other things that I wanted to highlight to the group were the work that we are progressing in terms of taking a leading role in the system-wide neurodevelopmental transformation programme. We know that we don't have our neurodevelopmental transformation pathway right across the whole system. This isn't just within CAMS, although CAMS plays a very important part of that. We are working with partners in local authorities across the 3 local authorities, the voluntary care sector, and trying to learn from other organisations about how they best deliver that pathway. And I think we are working pretty hard and to get a pathway that will be more lean and efficient, but also mean that people enter the system at no sort of wrong front door, and escalate children up for diagnosis where appropriate, but direct children who don't need an assessment for diagnosis appropriately to other services. So it's a very challenging picture. I think in terms of the other actions, the other recommendations, we've made good progress, and I've outlined those in the report. But I guess I just would like to pause and take any questions at this point for anybody.
Okay, thanks, Paul. I've got 2 questions at the moment, Jeffrey, and then I've got Deborah. So, Jeffrey, would you like to ask your question?
Yeah, thank you very much. It's on the recommendation 1. I'm speaking as an absolute layperson, but I'm reading this. To me, well, first of all, I don't know how you decide what is urgent and what is routine. If you could explain in lay language how you decide, that would be very grateful. But for me, who's an absolute layperson, for an urgent appointment, 4 weeks seems a long time for something that's urgent. I know from a layperson's point of view, if you've got a child with these problems, 4 weeks seems a long time. Are we not better in making the routine ones a bit longer, but the urgent ones a bit shorter? Your comments I'd appreciate. Thank you.
Okay.
Jim.
Okay, no problem. So urgent referrals are children for whom might be experiencing things such as thoughts about ending their life, but not have any sort of active plans to do so. Children that have a complex presentation that affects their ability to attend school, for example, or that there are significant safeguarding issues or disruption to sort of family life. That it's important to remember that there's another sort of level up from urgent referrals, and that's our crisis referrals. So all of our crisis referrals, which are acute, sort of absolutely pressing mental health need, are assessed within 2 hours and triaged on a telephone assessment and then followed up within 24 hours. So there is another sort of level up from urgent CAMHS referrals.
Okay, thanks, Paul. Could I just, Deborah, before I call you in, can I just ask Jane? I know Jane Moore's got to leave us at 3, so can I just ask Jane, you've got your hand up. Would you like to ask your question just in case we run out of time? So, hi, Jane.
Thank you, Chair. Oh, I really appreciate that. Thank you. I guess it's an observation, I think, more than a question. It's the concern around the bit that you've presented around the kind of numbers of referrals coming in and how ably we're able to deal with those children. And my concern is that as a system, we're not in a position to be able to actively support children, bearing in mind what we know about the impact of the pandemic so far on children. And I'm just looking at the report from the Children's Commissioner today that has again highlighted issues of mental health. And so it's more of an observation that I think we probably do need to take this to the Children and Young People's Design Group to really have a look at what our collective response to children's mental health needs to be, bearing in mind the pressures that obviously the CAMHS service is seeing. Those, interestingly, the pattern of referrals you're talking about do mirror what we're seeing, for example, within children's social care. But we're able to respond partly because we had a dip. So referrals have gone back up, and we know that schools being open has readily identified those children. But it's more of an observation really around the concern that we've got this cohort of children that aren't able to access the support that they need, and that we do need to look as a system around what we do to tackle some of that.
Thank you, Jane. I think that's really helpful. I think it's fair to say, pre-pandemic, as a system, we've worked really hard, I think, not just in health, but local authority and the voluntary sector, to really improve the offer around sort of building resilience for young people as well as lower level support. But you're absolutely right. You know, the wave of increased complex referrals is something that's replicated nationally, and it's something that's going to be a real challenge to us as a system, because we are creaking without a doubt to manage the demand, and we're seeing it reported every day, aren't we? Not just locally, but nationally.
Okay, thanks, Paul. Thanks, Jane. Deborah.
I think Jane's just stolen my thunder. That was pretty much what I was going to say. You know, we're not in a good place at the moment with children's mental health, and it's certainly not going to get any better very quickly. And yeah, we really need to get this right. So just any support we can do as a local authority, because this is huge, with such a knock on for schools, for social care. If we don't get this right, and it's the whole service partnership's going to break down unless we do something to tackle this. So just really something really urgent that we need to get on with and sort out, and any support that you need from the local authority, just get in touch. But you know, we really need to tackle this.
Thank you, and I just want to echo what I said earlier. You know, the newer developmental transformation work, you know, it's not going to be a panacea to this. You know, let's be clear about that. But you know, newer developmental referrals account for getting towards half of our work in CAMS, but I have to say we've had really good engagement from all three local authorities with the transformation programme, because I think we can do a lot more to get that right. So yeah, so thank you for that.
Okay, thank you. Next I've got Phil King. Thanks, Phil.
Thanks, Chairman. I've got two hats on for this report. One as a district council leader representing the 7 other districts in Leicestershire, and another as a parent of 2 children. Well, they're not children now, they're young adults who've been through the CAMS process. And I know we're on a public meeting, so I will be polite about it, but I don't see this as being a very positive report. In fact, actually, it's pretty bad, I think. Given that allegedly attempts have been made to improve things. Maybe they are better than they were a few years ago, but it's still not good enough. It's still not. If you're a parent of someone who's, as you put it, neurodevelopmentally challenged, to use the jargon, I can assure you a day, let alone 4 weeks, or in my personal case was months, that is a lifetime. For the children, for the adolescents who are growing up and developing, and for the parents who haven't got an absolute Scooby about what they're doing or how to deal with things. And the longer it takes before there is professional input, the harder it is for all concerned, the harder to get a positive outcome to turn those things around. And it impacts on schools, it impacts on children's social services across the board. So this is absolutely critical to get this right and to get this working and firing on all cylinders. And it's gone on, quite frankly, for far too long. Not just short term. This has been going on for years. Okay. Now, is it about funding? If it's about funding, then we as a Health and Wellbeing Board need, in my view, Chair, need to start making a lot more noise to the government, because at the end of the day, you're funded by the government, the Department of Health. And if it isn't about funding, then what's it about? Now, this report doesn't address that, but we need to get this sorted out, end of, and stop messing around. That's how I feel about it. I feel very strongly about it. There's a lot of talk about children, but we're forgetting you deal with a lot of adolescents up to the age of 18, many of whom, like mine, have been very capable of going on to university, but the preparation for them to interact in social life, in normal society, like put it, neurotypical situation, is very poor. It's scant. It's very difficult. So there are lots of issues, not just about waiting lists and about initial access to therapy or even diagnosis. And unfortunately, the system that we have in this country, without a diagnosis, you can't access a lot of other support. You can't access financial support, all sorts of things, and that causes immense harm, because it is very difficult for people to cope and not just emotionally, but financially and psychologically. So I think, COVID's just going to accentuate those things, make it a lot worse, as you already indicated. So I think it is really imperative, but we really need to understand, is this about money? So if you had the money, whatever you need to run these services, or is it about because you can't employ enough people, or is it there's a lack of people in the system that aren't trained to be able to deal with it, or is it, something completely different? And, Paul, with the greatest respect, I think that's what we need to understand now, because there's been discussion after discussion about CAMS isn't, waiting. I can, and there's colleagues I'm sure on this call who can go back and drag a report out from multiple years ago, and it said very similar things. And the only other specific point is I don't get the comment about the recommendation about public transport, and people who are neurodevelopmentally challenged don't like using public transport, most of them in my experience. So I do find that quite a curious recommendation of we need to get more young people to be using public transport to get to appointments. That is an incredibly difficult thing to do, and I am slightly surprised that's a recommendation. That's all I wanted to say, Chair. Thank you very much.
Okay, thanks, Phil. I mean, certainly from a user's point of view, I mean, the Healthwatch report in the first place obviously highlighted their views, which is obviously why we're here today with Paul from the LPT presenting his report. So if I can just go through, I've got a couple more speakers and I'll come back to you if I can, Paul. So it's I next have Andrew.
Thank you, Chair. Yes, just following on from those comments, I think really. I think that it's one thing, it's probably worthwhile noting that regarding recommendation 1, the time between referral and first appointment is one thing, but in my experience, a lot of the children and young people that present with difficulties and challenges don't always get accepted on the referral list first immediately, and so they've gone around the houses a little bit or a lot trying to find help and trying to work out what to do and who to go to and go to signpost the different services before they get to a point where CAMS is then willing to or able to accept them onto the list. So there is an element perhaps of looking at this perhaps a little bit wider and thinking about what's the time to first presentation and then appointment as well, rather than necessarily an accepted referral. And then to kind of move on from that a little bit, what I don't know is what the average length of time of an individual spends on the caseload of CAMS, and in order to sort of increase the numbers of people being able to access the service, there also has to be an exit strategy for some of the current users. So I'm just trying to think, well, is there a way? Are there sufficient step down services for existing users of CAMS? And are those services sufficient to support the children, young people and their families, so that they don't have to be at that level of using CAMS, but there are sufficient support services to be able to enable them and then could be stepped back up if required? I don't know the answer to that question, really. It's something I wanted to raise. Thank you.
Okay, thanks, Andrew. If I just go through the other speakers, I've got Helen who's indicated she wants to speak as well, obviously from the LPT. So I'll come to you in a minute, Helen. Willie.
Thanks very much, Chair. I'm grateful. It's a very interesting discussion. I agree with I have to say, with a lot that Phil King says on this. The crisis around child mental health has been going on a very, very long time now. And I think we sometimes see marginal improvements as though that's sufficient. And I don't think it actually is, for all kinds of reasons, one of which I'll come on to. And I think he's right. I think this is slightly depressing to read. But I want to acknowledge, from where I stand, the job I do, that I think LPT have done really a great deal in this whole area during the course of the time I've been around, striving to do so, but I think against fearful odds most of the time, and not least because of COVID and things now. So I want to say that to start with, but I want to go on to say that I'm not sure, it may be my ignorance, but it seems to me if the green, as referred to in paragraph 8, if this is the test for green, 4 weeks urgent, 13 weeks routine, I think perhaps it's time to look again at that assessment. If that's green, is it really green or is it amber? I mean, is it really good enough? I think it's the question that all of us should be asking, not just LPT, because it does seem to be a rather low level. And as I think Phil King made the point, 1 day is really too much. I would have thought 13 weeks for routine, actually, personally. It was a very long time indeed. So that's the next point I wanted to make on this. The other point really is this, that we're all kind of involved in this in a huge way, and not too much pressure should be put on LPT. And by all, I include government, and I think Phil King's absolutely right. I mean, local authority, LPT, police and crime commissioners, police can all do our bit and do our best. But actually, I suspect this is a matter of funding, fundamentally and staffing. And unless we grasp that, we will never really improve to the extent that we need to improve as a minimum. The consequences for all of us, of course, is that if young kids, adolescents, become mentally ill one way or another, the effects often are, or can be, not often, can be, of course, that they then begin to commit criminal offences, get themselves into trouble of some sort or another. And of course, that costs us all in every single way. So there's a real urgency, I think, in the need to try and improve this. I know LPT want to. I'm sure the County Council and everyone on this, all the district councils want to as well. And I do think it's fair here to say to government, and I think that's perhaps something that could come out of this meeting, say to government, look, it's not working. You've got to really do more in this field. Because in the end, I think it'll be them to decide whether this is going to be a system that doesn't work for the next generation, or whether we can actually do something positive about it. Thank you, Chair, and it's a pleasure to be on your committee, and this is the first, and may even be the last time I speak on it, depending very, very much on what happens on May the 6th. I see everyone laughing at that. But thank you for allowing me to make a contribution.
That's a pleasure. Thanks, Willie. I'll just take Christine. As I say, I'm going to go back to Helen and obviously Paul. I think certainly what you've heard there is a flavour from the board of the sort of concerns raised. But if I can just take Christine Radford, then I'll come back to you, Helen.
Just a quick one. Quite a lot of stuff's been said, but I from personal experience, I think trying to get even be able to talk to CAMS, even when the person involved was self-harming, they didn't think that was urgent. But then when you get on to the system eventually, is that we were amazed at how many changes of staff there were. You talk to one, then next time you've got an appointment, you're talking to a different one. So you've got to start again, and the child, is sort of going to meet the same one, then they've got to start again with somebody else. And one of the things that I've found is getting reports back from CAMS to help the parent then move on to get benefits or get even more support. Is, you have the parents' concern is having to keep ringing up CAMS and saying it's been a month and we still haven't had the report. And we've had meetings since, trying to get reports. The other thing that we do find is getting support from the school. The school don't really want to support any problem children. You can't get the support there at the school either. So, at the moment, of course, the children aren't in school, but when they are in school, they're not getting the support. But I think the biggest thing is the changing of staff and getting reports back from the CAMS, from CAMS to help you move on. Thank you.
All right, thanks, Christine. Helen, would you like to say a few words? I've obviously still got Paul here. You're more than welcome to comment, but Helen.
Yeah, so hello everyone, I'm Helen. So I'm representing LPT today, but I actually am Ops Director of the Families, Young People and Children's Services and Learning Disability Services as well. So hi. I think there's a few things really, particularly with Councillor King and Radford, because Councillor Radford, we have actually had conversations, haven't we, outside this meeting in the past, and and to hear that you're still experiencing difficulties, yes. It's hard, and I can really hear the distress from Councillor King in terms of working through those processes. We are obviously working really hard to improve services. But I think that I come back to Lord Back's response really in terms of the system response. And when the government have set out the plans for tackling emotional and mental health needs for children and young people, it's not about putting more money necessarily into the specialist end of the service, but it's about putting lots more money and people into the early intervention and early help end. So people will be aware that the mental health support teams around schools programme, we've been successful in the third wave, and we're just establishing at the moment 2 of our sites, which are Melton and Rutland, and then down in the south, Hinckley, across to northwest Leicester. What those sites enable us to do is to build a community of practice around a family of schools where we've got emotional mental health practitioners who are being trained up at the moment at Northampton, who will work with those schools and upskill and enable whole school approaches to tackling emotional mental health, but also provide some individual work. So what we're looking at trying to do is address the balance of trying to get into a specialist service with having more specialism at a local level. So the strategy, the government strategy, which for me seems to make sense, is that we need to build that early help and build resilience, and then the early help element to prevent more children coming up into specialist services, because obviously that's where there's always a sort of a pressure point there, and we've seen that over the years. I mean, they're looking at more workers in the mental health support teams than there are in specialist services by the end of their plan and projections. So we're just starting out on that journey, and we had our Children and Families Board yesterday, didn't we, Councillor Taylor? And we said that we'd report back on progress for the first 3 months at the next Children and Families Partnership Board that reports into here on the mental health support team around schools initiative. We've also really strengthened, and I've got obviously the commissioners on this call, but we've strengthened the early intervention offer that Relate provide, as well as the online counselling offer that Couth provides. So we're not the sole provider of services that support and help children and people who have got emotional and mental health difficulties. And we're working together as a whole system and looking at the moment, we're refreshing the plan for the system, and it would be very helpful, obviously. We're going to be circulating that and getting some young people involved in how that plan looks, and we'll be submitting that at the end of this quarter. So again, that will be something that the Children and Families Partnership Board decided on. So I think it's about how, because we need something different, don't we? We obviously need a different approach, and we're committed to working sort of across the partnership with as in terms of how we collaborate as providers, and particularly building the offer around early years and schools, which is for us really important. So yeah, I think in terms of the overarching strategic vision, the Future in Mind plan, the refresh of that, is probably the thing that would give confidence around the direction, that we're not just looking at trying to do the same and get the same outcomes, which clearly isn't working, and we know that we've got a lot more to do. I don't know, Paul, whether you wanted to come in on any of that.
I just took a few notes, thanks Helen, on a few of the points that were made before, so would that be okay if I just come back on a few of those? Is that all right? I think you're on mute, Chair.
Yes, I was indeed. Yeah, I think I was going to come back to yourself, Paul, just to finish off your presentation to the board. You've obviously got a good feel for what the board members' concerns are and frustrations. And obviously, I think at some point it'll be good. Healthwatch have sort of brought this the report to you. You brought the report back, so it'd be good to get some updates as we go along, because you can see there are strong feelings across the board. So if you want to finish up, Paul, yeah, it's good.
Yeah, absolutely. Thank you, Chair, and I'd be more than happy to come back and give progress whenever. I just want to pick up a few specific points, if that's okay. So with regard to the recommendation 7, Councillor King, about the public transport, I mean, that was a recommendation from Healthwatch, and I think that was only based on one person's feedback. So yeah, I take your point on that one. It's we've just had to respond to it as it was.
Sorry, if I can just go in, Paul.
Yeah,
CAMS
sure.
isn't exactly accessible by public transport for most people anyway.
No.
But I just, sorry, didn't mean to chop you off, but that was my bemusement by that, if I can put it like
absolutely.
that.
And no, and you made a good point that actually for some of the service users, public transport is the last thing that they would want to use as well. So I think our response is about exploring different ways to offer contact. I also wanted to pick up on your point about the importance of diagnosis. I think that's really loud and clear as part of our neurodevelopmental transformation programme. You know, one of the key sort of 3 strands of that programme is that it has to be informed by young people and their families, and we're really hearing loud and clear that actually getting a diagnosis is so important to so many people. So I just want to acknowledge that point. I think leading on from that, you know, the neurodevelopmental pathway is not just a CAMS issue. This is a whole system issue, and I think quite a few people on the call have said that. This is something that's incumbent on all of us to sort out. It's not just for CAMS to sort out. The Children and Young People's Design Group have oversight of the transformation programme. As I said in my early presentation, we've got good engagement from all parts of the system, and that will inform a demand and capacity analysis in the system, a delivery model that we think is the best that we can do, but it will also highlight what we can do with the resources we've got as a system and what the gaps are. And I think that's probably the best starting point, rather than trying to think about us in little silos of how we contribute to that pathway. In response to the issue around not everybody accepted for CAMS referrals and people sort of wheeling around the system, the CCG commissioned the Triage and Navigation Service from the beginning of May this year, which is really a single point of access for all referrals for emotional, mental health and wellbeing, and that service then triage those referrals and appropriate them out to the right place, because as Helen mentioned, you know, we have a whole cluster of services under the umbrella of early intervention, mental health and wellbeing services for young people that actually are wholly appropriate for a large number of young people without them needing to come to specialist CAMS. Those services also can act as a step down out of CAMS. So we have really strong links with that, with the Triage Navigation Service. In terms of average length of time of caseload, that's a really complicated question, and it's complicated by, 1, the age that people come into our service, 2, what they come into the service for. So if we've got somebody who requires medication and regular medication review by a specialist CAMS practitioner, and they get referred at the age of 13, they could be with us till the age of 18. So it's a bit of a difficult one to pick out as a number. It probably wouldn't do it justice. And then lastly, the response to the is green really green in terms of our performance against our commission targets. I don't know if Rachna wants to come in, but I think that that's a fairly standard national target for our assessment pathway. We just report against that pathway. So I don't know if Helen or Rachna, you've got any more on that.
I think just to say that the long-term plan has an ambition that all children and people would be accepted within 4 weeks. That is the long-term plan, isn't it? And that will be phased in over the next 5 years alongside the mental health investment standard.
Thank you.
Sorry, Chair, can I just come in and say, Paul, that you didn't pick up the fact that sometimes the change of staff, so that doesn't help a child that's got mental issues. You know, you see somebody twice and then they disappear. and then also how long it takes sometimes to reports to come back. I mean, we've waited 6 weeks and keep ringing up for reports to come back when they've had a meeting, and I don't think that's satisfactory either. So I think that needs looking at.
Sorry, I forgot to pick those points up. I absolutely agree. That isn't okay, and I will feed that back. I will say we've done a lot of work trying to work through job planning with all of our staff to make sure that we do have some consistency. But it's clear from your feedback that we need to do some more work on that, and in addition with our admin processes, because that's not okay for you guys to be chasing 6 weeks later for a report. So I will take that back. Thank you.
Okay, thanks, Paul. I think, as I said, I think that's once again been a good discussion, and concerns and sort of views of board members, both from their own sort of expertise and areas, and also personal uses as well. So we are asked now to note the partnership trust response, and obviously we have said that what would be good is to get at some point in a timely manner updates on this, because it was certainly strongly felt around the room. So can I thank Paul for his presentation, obviously Helen for joining in as well, and can I thank members as well for some good questions. So the next item is a report on our Better Care Fund plan for 2021, and John Wilson, our Director of Adults and Communities, will introduce a report which seeks our approval of the plan. So John, over to yourself. Thank you.
Thank you, Chair. Well, following that very in-depth conversation discussion, excellent report. I'm afraid I have a couple of quite dry technical reports for the board. It's perhaps a bit of balance. So we have the latest of the BCF reports, the Better Care Fund report, and as previously reported, we were awaiting policy guidance for 2021, which was finally published on the 3rd of December. So as expected, the guidance confirms that we will not be required to submit plans for assurance during this financial year. But we must ensure that we spend the money against the national conditions, and those are outlined at paragraph 10 of the report, and that funding is placed in a Section 75 agreement with appropriate governance in place. It's also worth noting that the statement that came out on the 3rd of December also confirmed the various funding elements for the Better Care Fund for 21-22. So that would include the Better Care Fund, which is payable through the clinical commissioning groups, and that contribution would again increase by 5.3% in line with the NHS plan requirements, and the improved Better Care Fund, which is payable through the County Council, which will be maintained at the current levels. The policy framework and planning requirements for 21-22 are due to be published in early 21, according to the statement in December. Now, given that we haven't had a policy statement within any of the last 3 years before September, that would be a remarkable achievement, I have to say. So whilst there's no requirement for us to submit a plan for assurance this year, there is a requirement that we submit a plan at the end of the financial year detailing what we've actually spent the Better Care Fund on within 2021, and ensuring that we have met all those national conditions. So paragraphs 14 and 15 of the report summarise the narrative and the financial plan, and we've included the full financial plan at Appendix B. We're not anticipating at this point any changes to that plan between now and the end of the year, but should there be any changes, we're asking the board to agree that the Chief Executive, in consultation with the Chairman of the Health and Wellbeing Board, could make any amendments and sign off the plan. So I'll leave it there. Thank you, Chair.
Okay, thank you, John. Does anyone have any questions related to what is an annual occurrence at the board? Any questions for John regarding the Better Care Fund plan? I'm sure you've all seen many versions of it, and as it's come through to us today. So 3 motions proposed, as I say, that it's approved. Any changes, obviously, as John raised, that the Chief Executive of Leicestershire County Council, following consultation with myself, be authorised to finalise the BCF plan and submit to NHS England. And that it be noted that the NHS policy statement did not set national metrics for 2021. So I've got no questions. Are all board members happy that be approved? Okay, thank you. Next item, again, which is over to John, is the Better Care Fund Section 75 Agreement, Approval and Assurance. This report provides the report with an update concerning the refresh of Leicestershire Better Care Fund Section 75 Agreement and seeks approval to continue with pool budget arrangements. So, John, over to yourself. Thank you. You're on mute this time, John. So it's.
Thank you. So yes, as we've just noted, one of the requirements of the Better Care Fund is that the fund is pooled under an agreement under Section 75 of the National Health Service Act 2006, and that we have appropriate governance in place. The original Section 75 agreement was developed in 2015. It was written on the basis that there would be a rolling review, and the most recent review has just been undertaken. The last review was undertaken in 1920, and I think we brought a report to the January board in 2020. So the Section 75 itself is there to facilitate the commissioning and provision of services as set out in the plan. It details the financial contributions and the commissioning of services. It details the operation and management of the pool budget, and it goes through the various eligibilities and the respective roles and responsibilities of partners. As part of the review this year, we've also determined that a variation to the agreement needs to be made to cover the COVID-19 discharge requirements, and that those requirements are essentially the provisions that were put in place in March of this year around discharge to assess, which includes the provision of up to September of this year the NHS funding any care that people received post-hospital admission, and from September, the first 6 weeks of that care. So that's now as part of a variation to the Section 75 agreement. First part of the agreement just outlines the general terms and conditions. Part 2 of the agreement provides a template for specification of any additional schemes, and those schemes are then specified in Part 3 of the agreement. Schedule 2 of the agreement notes that the partnership board the Section 75 agreement requires a partnership board to be established to oversee the governance arrangements, and for the purposes of this Section 75, that partnership board is the Integrated Performance and Finance Group. So the board's being asked to approve the continuation of the Section 75 agreement with the addition of the variation to cover the COVID discharge arrangements.
Okay, thanks, John. Again, do members have any questions or comments? It must be John's definition of it being a dry report, so there's no appetite for it. So I'll take the fact that there's no hands raised. Obviously, John's outlined the proposed motion, so are members happy? Just a show of hands to make sure we're happy to do that and move that forward. That's brilliant. Thanks very much. Thank you. Thanks, John.
Thank you.
Finally, item 9 is Healthwatch Leicester and Leicestershire update. Unfortunately, Mukesh had to apologise fairly late on today, so I think Harsh is going to try to talk us through the report, which provides an overview of the recent changes at Healthwatch Leicester and Healthwatch Leicestershire, along with an outline of the current structure and also future plans. So Harsh, if I can, I'll hand over to yourself. Thank you.
Okay, thank you. So I'll take the report as read. I think the reason for giving you this update is we've had a number of staffing changes in Healthwatch, and we just wanted you to make you aware of where we are in terms of the staffing structure. So Michael Smith, who had been a manager at Healthwatch for a fairly long time, and probably many of you knew, left us late last year. We went through an internal recruitment process, and we now have Mukesh in place as the chief officer, and we've also appointed a deputy manager, and Gemma Barrow, who you probably also met because she was on the previous Healthwatch contract working on that. So we now also have we've got 3 currently community outreach leads, and what we've done is change the way that we work, whereas previously we'd got outreach leads looking in terms of having one leading on the city and one leading on the county, and we're finding that wasn't quite working for us. So what we've done now is given the remit for all of them to work across the city and the county, so that there's always some continuity of care, continuity of the projects that we're working on. So we've changed that. We've currently got about 6 projects that we're working on, and all of those are highlighted in the report, and our plan is to end them at the end of this quarter, 31st of March, and we're currently reviewing, going through our database at the moment to see what is highlighted as a current issue, and I'm meeting a number of colleagues over the coming weeks to look at any issues that they feel might be appropriate for us to take on as priorities for the coming year, and then we'll be able to let you know what those are as soon as we've agreed them. We also have a new board member that's joined us. We had one leave us at the end of last year due to other commitments. So we've got a new board member as well, who comes from a patient participation background and got lots of leadership experience. So I'm sure you guys will meet him in due course as well.
Okay.
That's about it.
Thanks, Harsha. I mean, I think certainly the report you presented earlier, the Using Child and Adolescent Mental Health Services, should be revisited at some point, just to see if, even if you should use the same measurements and metrics, it would be interesting to see what the perceived perception was from those service users as well. So, do any board members have any comments or questions for Harsha? Are we all happy? I think the work you do is. I've got Phil. Phil's raised his hand. So, Phil, do you have a question?
Yeah. Thanks for that. Hi, Harsha. No, really, it was just really. Are you? Because in your report you talked about COVID-19. So obviously, one of the effects is obviously, a lot of medical and social care activities being diverted rightly onto dealing with the acute and the longer term effects from COVID, but obviously some of that is is having an effect on other services. And I'm just wondering, at some point, are you going to take a dive into that to have a look at that? Because some of the feedback I've received from residents about changes to services is, whilst on the one hand some of them quite like it, others don't like it and find it quite hard to access. And there's a bit of, a tension between that. And I'm just wondering, is that really working for people? And how do we know? And are you going to be able to take a look at it?
I think that's one of the things that we have actually discussed at our board, because early in the pandemic, we did work with the CCG to look at what the impact was of COVID at the start. And there was a report that was presented. We put a survey out and a report was presented. And one of the things that came out was that there's still a lot of people that have got the idea that some of the services are going to go back to the way that they were before the pandemic hit. And as we've already heard, that's not likely to be the case. Some will go back, but the majority of them, we're moving in a different direction now. A lot of people are more accepting of online provision. So it is something that we're planning to look at in terms of how people feel about those changes, and are they happy with them, and if there's something else that can be done to support them further.
Okay, thank you, Harsha. And I've also got Mayor.
Yes, really building on that, I would like to suggest that future themes for exploration would be the post-pandemic issues, so reset, recovery, restoration. There are thousands of operations which have been cancelled or postponed. There'll be a backlog of long-term conditions review. I mean, this is big stuff, right? It's going to be massive. Now, I think the voice of the public and the client has been a little bit quiet during the acute phase, and that's understandable because, it's a pandemic, it's an emergency, people are in lockdown, right? And we're focused on treating people who are acutely ill, like the 500 people in UHL at the moment, many on ventilators. But I think as we build the post-pandemic NHS and care, we need to hear from patients and citizens and because we'll have to make choices about priorities.
Yes.
And the models of healthcare will change greatly, because I can't see general practice going back to feel like its normal way. And digital first is one of our principles, not digital only. There'll be a range of ways of accessing care. But I think well-being, access to services, what we decide is important. And, you know, the patient perspective will be so important. So anything you can do to understand that will be really helpful.
Yes, yeah. And I think we're already hearing about some comments from patients about the changes. So certainly one for us to look into a bit further.
Okay, thank you. Thank you, Harsha. I've got no more questions, so I think we are asked to note the report and its contents, and I think we've commented obviously on your approach to promoting the needs of patients and communities across Leicester and Leicestershire. So can I thank you for the good work that you do? Please keep it up. And thank members for their questions. So the final item is just the date of the next meeting. The date of the next meeting of the Health and Wellbeing Board will be held on Thursday, the 27th of May at 2 p.m. We've obviously reduced the number of meetings, but can I remind members that we do have a development session which is planned on the 25th of March on the wider determinants and health inequalities. The date should be in your calendars. Joe's taken care of that with Matt. So this is promising to be an informative event and allows attendees a much broader view of wider determinants and health inequalities in Leicestershire, along with covering the partnership work underway to develop an LLR-wide health inequalities framework. So look forward to you working on that. As I mentioned earlier, item 11, there aren't any urgent items. So can I just thank the officers, Matt and Joe, for getting us here today and looking after us as always. A lot of work goes in. Can I thank board members for their attendance and also for all the speakers today. Please remember hands, face and space, and stay at home, protect the NHS and save lives. I think that's all we can say, and look forward to some sort of normality. I'm not too sure what normality will look like. I don't think it'll look like it did before this started. It seems to be in a very long sort of 10 months, but we can play a big part in getting that and making it happen. So well done. Keep up the good work and see you again soon. Okay, thank you.
Thank you. Bye-bye.
Thanks. Bye now.
Thanks all.